Welcome to the second part of Session 3 of the Public Health Surveillance course. In this session, we're going to delve into a detailed example of a notifiable disease surveillance system, namely New York City's HIV/AIDS surveillance system. As part of this detailed example, we'll cover the emergence of HIV in the US. I'll give an overview of the clinical and epidemiological aspects of HIV and AIDS. Then we'll delve into how HIV/AIDS surveillance is conducted at the local level in New York City. And then we'll end with some recent public health efforts that really rely heavily on HIV/AIDS surveillance, those that are aiming to end jurisdictional HIV epidemics as public health threats. This is the first published report of what soon after became known as AIDS. It was described first in the MMWR as a case series of 5 gay men from Los Angeles who had a very unusual presentation of pneumocystis carinii pneumonia. That was their clinical diagnosis. However, an important detail was that they were all previously healthy, and it was not clear what the underlying cause of the pneumonia was. It wouldn't be until a year later that the term AIDS was coined, and then there began to be a case definition for it, and then even longer before a virus was identified as the causative agent, the HIV virus. But it's important to start at the beginning, at least in the US, so you can get a sense of how surveillance began and how it evolved with the HIV epidemic as it unfolded. With time, epidemiologists came to understand that this case series was a manifestation of a wider outbreak that was ongoing, and that a common theme among the cases was that they were previously healthy individuals who developed severe immune deficiency. This in turn put them at risk for a host of very specific opportunistic infections, such as pneumocystis carinii pneumonia. But there were many others, as we'll see. In people with very weak immune systems, these kinds of infections are deadly. Ultimately, enough similar cases occurred that a case definition could be developed for what was ultimately called acquired immune deficiency syndrome, or AIDS. The initial case definition could only include clinical information because there was no laboratory test, because there was no diagnostic test, or it wasn't even known that it was a virus at that time. But that clinical case definition could still be used by health departments for case finding. This was happening even before it was known that it was a virus as the underlying cause of the outbreak, and the lab test would not become available for a few years after the outbreak began. So to assess the scope and monitor the outbreak, the CDC urged health departments to conduct case finding using the clinical case definition here, which was used from 1981 to 1985. It was primarily a clinical syndrome which included the diagnosis of one or more of 23 specific opportunistic illnesses. In 1985, that case definition could begin incorporating the serologic test that was developed after the causative agent of HIV was identified. A positive serologic test meant that a person was infected with HIV sometime in their past. And later, in 1993, the case definition was expanded to include some more opportunistic illnesses that were found to be associated with HIV and AIDS, as well as a laboratory test of immune deficiency called a CD4 test. If someone has a positive HIV serologic test and their CD4 count is below a certain level, even if they don't have an opportunistic illness, it meant that they have immunodeficiency and they met the case definition for AIDS. So health departments around the country began a combination of active surveillance or provider reporting, and laboratory reporting was added by 1993. Here's a picture of an old hand-drawn epidemic curve from the New York City Health Department that shows the results of some of the early surveillance that was going on in New York City in 1982. It shows the number of individuals that meet the AIDS case definition that were identified via active surveillance. And those methods would have included reaching out to hospitals and infection control nurses to ask specifically whether or not they have patients with new diagnoses of certain illnesses or with the syndrome described in the case definition. A lot of this is what has been called shoe leather epidemiology, which is that health department staff are going out to providers and hospitals and actively trying to find new cases and gathering the relevant information they need for surveillance. The slide shows AIDS cases for New York City and for the whole US by date of symptom onset. It's a little hard to see, but it shows that a large share of AIDS cases in the US were occurring in New York City. With active surveillance in place around the US, as of February 1983, there were about 1,000 AIDS cases identified by local and state health departments, and they were largely concentrated in cities around the US. Individuals who met the AIDS case definition were identified by health departments and reported to CDC, who used them to compile national statistics and maps like the one we're looking at here. An outbreak of 1,000 cases of a deadly disease with an unknown cause was a basis for continued active surveillance for AIDS. Why is AIDS surveillance important at this point? And what are some of the goals of AIDS surveillance, of an AIDS surveillance system in 1983, early on in the outbreak? At this point, epidemiologists still didn't know the causative agent. They didn't have a laboratory test for it, and they really didn't understand the risk factors. In a situation like this, while they couldn't yet use surveillance to help target prevention and treatment, since there's no understanding of the etiology or how to prevent or treat the condition, surveillance was useful mainly for monitoring and characterizing the HIV epidemic, and this can help better understand its distribution and risk factors and natural history, all of which became critically important. By 1985, there were 10,000 AIDS cases reflected in surveillance, and this is a point when it was known that there was a virus that was causing AIDS, and serologic tests became available. You can also see that the epidemic had begun to spread beyond some of the initial cities where it was reported from. This was the situation by 1989, when over 100,000 AIDS cases were counted in surveillance, with case counts rapidly growing in cities and also, though, beginning to spread into wider geographic areas around the country. By 1995, the AIDS surveillance system had recorded around 500,000 individuals who met the case definition. And by 1997, more than 620,000 AIDS cases had been documented by surveillance. Two important points. First, as we'll see, at this point in time, most people with AIDS died relatively soon after they were diagnosed. So many of the 626,000 people with AIDS that were reflected in the AIDS surveillance system in 1997 were already dead. Secondly, AIDS cases don't represent all people living with HIV. They represent those people with HIV whose infection has progressed to the point of developing AIDS. As we'll see, this is a process that usually takes years. And we'll talk about the natural history of HIV in a minute, but AIDS cases really only represent the so-called tip of the iceberg of the epidemic, and AIDS surveillance did not track people with HIV who had not yet developed AIDS. However, in 2003, the CDC estimated that there were 1 million people living with HIV in the US, including those without AIDS. Once the HIV virus was identified as the causative agent, it became possible to do more focused research studies, sometimes spurred by information gathered from surveillance about potential risk factors. For example, research studies could begin to study what factors were associated with the risk of HIV acquisition and also quantify that risk. This table nicely summarizes the findings of such research studies that were able to quantify the risk of acquiring HIV infection in relation to different kinds of exposures. The numbers in this table represent the risk of acquiring HIV per 1,000 exposures to an infected source. So on a population level, every 1,000 times an HIV uninfected person uses a needle to inject drugs that was just used by someone with HIV, we would expect 6.7 new HIV infections to result. For an individual who's HIV negative, they would have 6.7 out of 1,000 chance of acquiring HIV each time they used a needle to inject drugs that was just used by someone with HIV. So you can think about it in two ways, on the population level and on the individual level. For the table, the higher the number, the higher the risk. And you can see that not every kind of exposure to HIV comes with the same risk of HIV acquisition. But you can see which kinds of exposures are associated with more risk, and these were important to know. The quantification as well as all the different possible modes of HIV transmission, because then you can begin to think about preventing HIV infection as a part of the public health response to the epidemic. As we alluded to in the last session, to understand how the surveillance systems work and how surveillance systems were designed for AIDS and HIV specifically, it will help to understand a little bit about the HIV life cycle and the natural history of HIV infection. This schematic shows the HIV virus, a retrovirus, in red with the little green dots poking out of the outer shell of the virus. The larger circle represents the immune system cell, the CD4 cell, which is a type of T cell that is the target of the HIV virus, and it's related to the laboratory tests I mentioned earlier. The HIV virion makes its way into the CD4 cell and introduces RNA material, which is turned into the DNA of the HIV virus. The DNA enters the nucleus of the CD4 cell, allowing the virus to use the CD4 cell machinery to reproduce and multiply. Eventually, there are so many copies of the virus produced inside the CD4 cell that there's no more room and the cell bursts and is destroyed. It's the virus replication that specifically targets these major infection-fighting cells of the immune system that results in the extreme immunodeficiency that puts people with HIV at risk for opportunistic illnesses. And that's the cycle of HIV, that's the HIV life cycle in a nutshell. And this slide shows some basic information about the natural history of untreated HIV infection. That is, what would happen to someone infected with HIV were they not ever to get access to treatment, which was essentially the reality of the first 10 to 15 years of the HIV epidemic after it was reported in the MMWR. The x-axis shows the time from HIV infection from the first 12 weeks all the way out to 11 years. The left side of the graph is for the blue line, which shows the number of CD4 cells per cubic millimeter of blood, also known as the CD4 count. A declining CD4 count indicates increasing immunodeficiency. And the right side of the graph is for the red line, which shows the number of copies of the HIV virus per milliliter of plasma, also known as the HIV viral load. Initially, between 0 to 3 weeks after HIV infection, there's a spike in the amount of HIV virus circulating in plasma. A spike in the viral load, that is. As those viruses enter the CD4 cells and replicate, they begin to destroy the immune system's CD4 cells. And that's why you see a rapid decline in the number of CD4 cells. The body's immune system tries to combat the virus and begins to get it under control, but eventually, after about a year, the virus slowly begins to take hold and ultimately defeats the immune system. After about 8 to 10 years after infection, the CD4 cell count becomes so low that the risk of opportunistic infections increases rapidly. So thinking about this natural history timeline and thinking back to the people with pneumocystis carinii pneumonia identified in Los Angeles in 1981, they actually represent HIV infections that occurred in the early 1970s because of how advanced their HIV infections were. So here you can get a sense of how understanding the natural history of an infection can give important insights into epidemic behavior. And the important thing for surveillance is that without treatment, there's progressive decline of CD4 count that occurs over time. And after about 8 to 10 years, those infected will develop AIDS. All of this is in the absence of treatment. The discovery of effective treatments, which we'll discuss next, changed everything, including, as we'll see, the goals of surveillance for AIDS and HIV. Once a virus was identified as the cause, there was a lot of research effort aimed at identifying treatments that would work against HIV, and many of them failed. That is until around 1994 or 1995, and reported in the New England Journal of Medicine in 1997, when 3 antiretroviral drugs in combination were found to be very effective at treating HIV infection. This so-called triple therapy or highly active antiretroviral therapy, HAART, was a 3-drug regimen with complementary mechanisms of action to disrupt the HIV life cycle and inhibit viral replication. It was shown to be superior to a 2-drug regimen and to a single-drug regimen, neither of which worked very well. So shown here in the graph on the top left, you can see that compared to a 2-drug regimen, The 3-drug regimen was more successful at reducing HIV viral load over time. And on the top right graph, you can see that the triple therapy was more successful at increasing the CD4 count over time, and thus restoring the immune system. And this in turn reduced the risk of opportunistic infections that would otherwise happen. This is a slide that the New York City Health Commissioner in 2003, Tom Frieden, put together that summarizes the ways that HIV treatment improved health outcomes. He said that effective HIV treatment prolongs life. In fact, people who start treatment early and maintain it will have normal life expectancy. It delays progression to AIDS, which has implications for HIV surveillance, or for AIDS surveillance, I mean. It reduces the risk of hospitalizations, opportunistic infections, and drug resistance. And lastly, it was a novel idea at the time, but Frieden maintained that HIV treatment would also greatly reduce the public health concern of HIV spread. So there's this idea that if the amount of HIV circulating in plasma could be reduced through treatment, it would also be lower in the bodily fluids that were linked with HIV transmission risk factors, making people on treatment less likely to spread HIV to sex partners, needle-sharing partners, and during pregnancy, childhood, and childbirth and breastfeeding. So this concept of treatment as prevention, as it was called, turned out to be proven quite definitively later on. But it's something that Tom Frieden and a few others felt strongly was the case even before it was borne out in research studies. So we saw on the maps what AIDS case reporting data was telling us, which we'll come back to soon, but as we know, AIDS is rapidly fatal without treatment, and when people die from HIV, it will usually be listed as the cause of death on death certificates. That means that another relevant source of data for AIDS surveillance is vital statistics and mortality data. So what does the vital statistics data tell us about the HIV/AIDS epidemic? HIV spread rapidly and infected enough people and was so deadly that it quickly became the leading cause of death among all persons in the US aged 25 to 44. And you can see that beginning in 1994 and 1995, when treatment started to come online, the rising trend in the death rate was stopped and reversed. And the number of HIV-related deaths were greatly reduced in subsequent years. This dramatic decline represents the impact of highly effective HIV treatment that came online, and the continued year-over-year declines also largely reflects the effects of treatment, since HIV incidence didn't really change that much over this time period. And in the graph on the right, you can see more recent data on the trend in HIV-related deaths, national data. It remained fairly stable, suggesting a steady stream of people with HIV were not benefiting from available HIV treatments, likely due to access and challenges that many people with HIV face, such as those who are homeless, mentally ill, or have substance use disorders experience when they're trying to maintain consistent adherence to daily oral medications. The latest advances in HIV treatment now include long-acting injectable treatments, which are injections that only need to be taken every few months, and these may hold promise for further reductions in the HIV death rate. There's now about 1.1 million people living with HIV infection in the US, and most are on treatment. And you can also see how disruptions to treatment that occurred as a result of the COVID-19 pandemic resulted in the first increase in HIV-related deaths in decades. It's most likely because of disruptions that occurred in people's access to care and medications. So now we're in an era of HIV treatment, at least in the US, and we know that treatment is something that delays the progression to AIDS. And we also know a lot more about the different ways that HIV can be transmitted. So if treatment delays the progression of HIV to AIDS, then it changes the meaning and utility of reported AIDS cases and AIDS surveillance itself. So once the treatment era began in the US, there was a push to think about the purpose of surveillance again. What should it be used for, given that there is more known about the epidemiology, risk factors, and things that drive the spread of HIV/AIDS? And also, what should surveillance be used for, given that there are now highly effective treatments available? So this is an example of how the goals of surveillance sometimes need to change. Surveillance could potentially be used to track what could be changing patterns of HIV transmission, and it could be used to systematically inform the equitable targeting of federal and local testing, prevention, and treatment services and other resources. This is an epidemic that affects all the states around the US, and some more than others. And it became important for the federal government to figure out how it was going to fund treatment for HIV and AIDS. Surveillance data were and still are a major source of information for that purpose. So HIV surveillance was always important, but why it was important has continually changed. A particular point I want to make here is that it became clear that surveillance only tracking cases of AIDS, which occurs, as we saw, 10 years after HIV infection, no longer seemed viable as a means of understanding the distribution and behavior of the HIV epidemic. That is, if at one time AIDS case reporting could be used as a proxy for what was going on with HIV transmission, say 7 to 10 years earlier, that was no longer possible in the treatment era. In the treatment era, AIDS cases occurring in a given year meant something very different now, and also very important though. Namely, it tells you who's being diagnosed late and also who's not able to access or benefit from new treatments that prevented progression to AIDS. So to address some of these priorities, AIDS surveillance needed to evolve into HIV and AIDS surveillance. And this is what CSTE and CDC recommended. CDC strongly recommended that all states and jurisdictions transition away from just counting AIDS cases to counting all cases of HIV, including those who had not yet progressed to AIDS. And this slide shows a map of all the states and the years in which they went on to expand their surveillance to include HIV cases and not just AIDS cases. As of today, all states across the US have adopted named HIV case reporting, and New York State did so in the year 2000. So what do the national notifiable disease surveillance data say for both HIV and AIDS? What do they tell us? So this is a map showing the rate of new HIV diagnoses among adults and adolescents in 2021. There were about 36,000 new HIV diagnoses in that year around the country. And if you calculate the rate per 100,000 population and map it, you can see that the rates of new diagnoses of HIV were highly variable by state. Recall that earlier in the outbreak, the coastal cities were the most affected, including New York, California, and Florida. And as you can see in 2015, the southern US, including Florida, have the highest rates of HIV. In addition to where cases are occurring geographically, as shown on the maps, the surveillance data can also tell us about who is most affected and the trends. So this trend graph is showing the trend line in the number of diagnoses by sex, and you can see that in the US, at least, the HIV epidemic is affecting males much more than females. The CDC doesn't break out trends in new diagnoses by sex or gender anymore, but the sex differences still hold, and they've both continued to decline over time, albeit slowly. As part of surveillance, information on the likely mode of transmission is collected on persons with newly diagnosed HIV. So people can be classified into whether or not they likely acquired HIV through male-to-male sexual contact, heterosexual contact, injecting drug use, or if they had a combination of risk factors. And you can see here that the overwhelming majority of new HIV diagnoses, the highest proportion are occurring among men who have sex with men, followed by heterosexual contact. And those were for HIV diagnoses, but this is just going back to AIDS cases for a minute, because the HIV diagnosis data don't go back this far. But this slide shows the proportion of AIDS cases by race ethnicity. And beginning around the mid-1990s, when treatment that prevented progression to AIDS became available, you begin to see a decline in the proportion of AIDS cases among non-Hispanic white people and an increase for all other race ethnicities, especially among non-Hispanic Black people. And this suggests access to and uptake of HIV treatment is differential and inequitable. And moving back to HIV diagnoses, going from 2010 now, you can see that by 2010 and well before, the share of HIV diagnoses that was once highest for non-Hispanic white people was now highest among non-Hispanic Black people, who make up a much smaller proportion of the U.S. population. And the same became true for Hispanic and Latino people by 2016. So you can begin to see the racial and ethnic disparities that are and the ways in which the HIV epidemic was differentially affecting minorities. Using surveillance data and other sources of information, the CDC estimated that about 1.1 million people aged 13 and older were living with HIV infection in the United States as of 2021. It includes an estimated 10 to 15% of people with HIV who are not yet aware of their infection status. And this is an important group from an epidemiologic and public health standpoint. If someone has HIV infection and is not aware of it, they may be more likely to transmit it to sex and needle-sharing partners. So finding these cases through testing and diagnosis and diagnosing people earlier could have a significant impact on the trajectory of the HIV epidemic. So looking at the distribution of those 1.1 million people who are estimated to be living with HIV in 2021, stratified now by gender, age, race, ethnicity, and risk factor, can be important and insightful. You can see most people living with HIV in the US are male, age 35 and older, non-Hispanic Black, and are men who have sex with men. And with such large numbers, it's possible to stratify even further. And here's an example of why it's important to stratify by socio-demographic factors as well as risk factors. So you can see stratifying people here living with HIV by both sex and risk factor. If you look at males on the left, you can see that 70% of the HIV cases or HIV diagnoses were among men who have sex with men, followed by heterosexual contact and injecting drug use. On the right, among females, it's mostly heterosexual contact, with 74% of the cases that occurred among women having as their only risk factor, having heterosexual contact as their only risk factor. But a significant proportion, 21%, also had a history of injecting drug use. Surveillance data would suggest that strategies to prevent HIV need to look very different for males and females in the US, for example, and other stratified analyses can yield equally important insights. A major success story, which happened pretty early on, as shown here, was reducing the number of perinatally acquired HIV infections in the US that happened as a result of HIV transmission during pregnancy, childbirth, and breastfeeding. This was accompanied through testing and treatment of HIV during pregnancy and after childbirth. It greatly reduces the risk of vertical HIV transmission. And this approach has become a major component of HIV programming all around the US, such that now, even though we have many thousands of pregnant people living with HIV around the US, we have very, very few cases of perinatally acquired HIV today. And moving on to deaths, this slide shows the distribution of HIV-related deaths by state, with about 20,000 HIV-related deaths occurring in 2021. So by now you know that these national data that I've been showing on the last few slides from CDC, they come from providers and labs, right, that have reported information on HIV diagnoses and laboratory tests to local health departments. And these local health departments, in turn, report them to their state health departments, and they are the ones that ultimately report it to the CDC. At CDC, they can be aggregated into the national statistics that I just shared, and we can examine all of those trends and maps and graphs and things like that. So these national data are useful and have an important role, but another important question to ask is the extent to which national data provide useful information for public health action at the local level. I would argue that every jurisdiction's HIV epidemic can be a little bit or maybe a lot different. And while we know from national data that certain groups are more affected, the distributions could really differ substantially when you drill down into different localities. So it's important to remember that when you're seeing the national HIV surveillance data, it's really an aggregation of a bunch of different heterogeneous local HIV epidemics, kind of like an average. And it becomes important not only for state and local health departments to report their data up to the national level, but also for those state and local health departments to carefully examine, interpret, and disseminate their own local data, because this is where most public health action can take place, and it needs to be informed. So drilling down to the local level to explore this a little further, we'll look at the building blocks and inner workings of New York City's surveillance system for HIV and AIDS. I was fortunate enough to be involved in the process of transitioning New York City's surveillance system from an AIDS-only surveillance system to one that included both people diagnosed with AIDS and those diagnosed with HIV who hadn't yet progressed to AIDS. So I'll try to describe the context at the time and how we went about this process of evolving one of New York City's largest and most complex public health surveillance systems. So let's set the stage for this. In terms of the surveillance system, New York tracked only AIDS cases until June of 2000, when new state regulations authorized surveillance to include people that were diagnosed with HIV who hadn't yet progressed to AIDS. New York City has been the epicenter of the AIDS epidemic in the US since HIV was detected, really. And leading in the year 2000, far and away, New York had more cumulative cases of AIDS reported than any other surveillance jurisdiction in the country, as you can see on the graph here. This city was very much affected by the HIV epidemic, partly because it was having more of an impact here, but also because we have many more people living here in New York. In the year 2000, when the census had just been completed, the New York City population was estimated to be about 8 million, and 36% of our population were foreign-born. About 48,000 people from the surveillance system were estimated to be living with AIDS, and that's per AIDS case surveillance that had been in place in New York City since 1981. But because the surveillance system only tracked AIDS cases, we knew nothing from surveillance about the persons living with HIV who had not developed AIDS. We were developing and about to implement a new surveillance system with an expanded case definition that would track HIV non-AIDS diagnoses in addition to AIDS diagnoses. And this slide shows how the HIV/AIDS surveillance case definition expanded in New York City at that time, or going back to 1981. From 1981 to 1993, AIDS case surveillance really included a clinical case definition for AIDS-defining illness with a positive serologic test added to the case definition in 1985 when that became available. In 1993, as we mentioned before, 4 new opportunistic illnesses were added, as was a CD4 count laboratory test that showed immunodeficiency. Both of those were added to the AIDS case definition, and the addition of CD4 testing to the case definition also brought with it new laboratory reporting requirements. So the plan in June of 2000 was to add HIV non-AIDS diagnoses to the case definition and surveillance system. And you can see how the new expanded case definition on the bottom half of the slide here, you can see the expanded case definition that adds HIV diagnoses without AIDS based on the results of serologic tests or a detectable HIV viral load test. Initially, in New York City at least, only detectable viral loads were reported by laboratories, which means that people who had never developed AIDS and had a CD4 count above 500 and were being treated successfully would not be immediately captured by this expanded case definition. This is because, as we saw, successful treatment suppresses the virus, keeps CD4 levels high, and reduces HIV viral load to levels that are undetectable in the blood, even though it was still present as an infection. However, after a few years of experience with the surveillance system, undetectable viral load test results, all CD4 counts, and HIV genotyping from resistance testing were added as reporting requirements by laboratories. How are the AIDS surveillance regulations implemented, and what's currently reported in New York City? Well, providers are required to report all new diagnoses of HIV and all new diagnoses of AIDS. They're also required to report known sex and needle sharing partners for the purposes of partner notification and other partner services like testing. Laboratories are required to report the results of positive HIV serologic tests and all HIV viral loads, both detectable and undetectable. All CD4 count tests are reportable, as are the results of HIV genotypic resistance testing. So we talked about the importance of engaging stakeholders, and here's an example of some of the provider education activities that happened around the rollout of this new surveillance system, which is aiming to alert and educate providers and laboratories about their reporting requirements. So in terms of active and passive surveillance, at the time in New York City there were about 75 hospitals, 500 freestanding clinics, and over 1,500 private medical care providers that could be diagnosing and treating people with HIV. From an active surveillance standpoint, all of these venues need to have health department outreach happening in some form or another. So you can begin to imagine the size of the operation that might be behind the active surveillance component of New York City's HIV/AIDS surveillance system. From the laboratory standpoint, more than 70 laboratories were licensed by New York State to conduct HIV-related tests on New York residents. And the test results from all of these laboratories were a major source of data being received that needed to be managed as part of the new HIV/AIDS surveillance system. We talked about the surveillance system attribute of simplicity, and HIV/AIDS surveillance in New York City is a big task, and the system is both complex and resource intensive. To give you an idea, at the time that HIV reporting was rolling out in 2001, there were 43 full-time core surveillance staff, 10 surveillance staff who were just dedicated to pediatric HIV surveillance, 4 data managers and database developers, and an annual budget of about $3.9 million. And most of that budget, all of that budget, in fact, comes from federal funds from CDC. And at the time, New York City was accounting for about 18% of all of the HIV and AIDS diagnoses in the US. I mentioned that in New York, the provider report form for HIV was separate from the universal reporting form that the city uses for all other notifiable conditions. And this is a picture of an early copy of that provider report form, so you can get a sense of what it looks like. I know it's hard to see, but this is the best copy I could get my hands on. It includes on it a place to capture identifying information and socio-demographic information, as well as information on risk factors or the likely mode of transmission by which the individual acquired HIV, and of course clinical information and dates on the timing of diagnoses and laboratory tests, which can be used to help determine the date of diagnosis and when the person met the surveillance case definition. Much of the second page of the provider report form for HIV is devoted to capturing information on sex and needle sharing partners, as well as details on the provider who made the diagnosis, which becomes important if additional follow-up is needed. One immediate consequence of the new surveillance regulations was a significant increase in the volume of information received from laboratories and providers. The slide shows the number of HIV-related laboratory tests by year of report. Just as an example here, prior to HIV reporting, the New York City Health Department received about 40 to 50,000 laboratory reports of CD4 counts less than 200, which were used for AIDS case surveillance. By 2001, after the implementation of the new HIV reporting regulations, more than 300,000 HIV-related laboratory reports were received. And this information needed to be incorporated in the field investigation process and also combined with information received from providers and medical records so that we could ultimately generate epidemiologic information that to use on the other end of this new surveillance system. So you could say that there's a lot of information that gets received by surveillance and a lot of magic happens, and out the other end comes epidemiologic information ready for dissemination and interpretation. But since we're in a surveillance course, you'll get to see behind the curtain a little bit, and so you can see how a lot of this magic actually happens. The next few slides will detail how this process of receiving data and reports from providers and labs and from active surveillance gets translated from data into useful epidemiologic information. In other words, the nuts and bolts of New York City's HIV/AIDS surveillance system and its epidemiologic inner workings. The HIV surveillance system is called HARS. It stands for HIV/AIDS Reporting System, within which exists information on every person ever diagnosed with HIV or AIDS in New York City. So it's actually a surveillance registry. So how is that registry constructed, and what happens when reports or other kinds of information comes into it? Well, first we have provider reports and active surveillance that contain information on new HIV diagnoses. Often active surveillance will identify a case that was not reported passively by providers, and often a case will be reported by a provider and more information might be needed because the provider report is incomplete. In that case, public health epidemiologists will go back to the provider and get the rest of the information that's needed to complete the case report. But all of this information ultimately gets into HARS. Importantly, there's also a deduplication process that needs to happen, because it could happen that two different providers report the same person as a case, or it could happen that active surveillance finds a case that's also reported from another provider. So inside of the surveillance system, there needs to be a robust means of deduplicating cases. We also have information coming from the surveillance system from laboratory reporting. And here it's important to note that a lab test by itself does not necessarily indicate a new diagnosis of HIV or even that the person tested has HIV. For example, a CD4 test is a test for immunodeficiency, which is done not only for people with HIV. It's a single CD4 test result, including one with a very low CD4 count, does not indicate that someone meets the case definition for HIV, since it also requires a diagnostic test for HIV. There are many health conditions that can result in immunodeficiency. A standalone CD4 test in an individual needs to be therefore investigated further, and if it can't be linked with other information on that person from provider reports or diagnostic laboratory reports, then it becomes less clear whether or not that person meets the case definition. And the point is that there are steps here that need to happen with laboratory reports before they can really be entered into HARS and constitute or be associated with a case. So let's delve into this a little further. If a laboratory report comes in and it represents a person who was never reported to the HIV surveillance system previously, then that could represent a potential new case, and it needs to go out for field investigation to gather some more information. Field investigation can confirm HIV status if the laboratory report is nonspecific, like a CD4 test, but also can be used to get demographics and other information that is not reported by laboratories. If a lab report comes in and it represents someone who has been previously reported to the surveillance system, that is, that person already has a record in the registry, then it becomes a matter of identifying that match and updating the record with the new lab test results. The new lab test results may have some significance, and we'll come back to that. Looking at the right side of the schematic again, if a laboratory test comes in that's a standalone CD4 count and it represents a person who's never been reported to the surveillance system before, then the first order of business is to figure out via field investigation if the lab report represents someone with HIV. If it does, then they'll have the possibility of being classified as a new HIV case in the surveillance system. If not, they'll be classified as a non-case. But it's also possible that in that situation, that if the case status determination remains uncertain even after field investigation, and that's because there may not be enough clinical or laboratory information to determine whether or not it is a person with HIV infection. These individuals go into a bucket called possible cases that you would revisit regularly to see if you have any new information that can help you further resolve the uncertainty about their HIV status. Another situation, moving to the right side of the schematic, is the previously unreported individuals who have some kind of lab result that indicates they have HIV infection, like a positive serologic test or a detectable HIV viral load, but not enough information to determine if the report represents a case that's already known to surveillance. Here, the main task is to determine whether the report represents a new case or not. If there's enough demographic information like names, social security number, date of birth or age, and gender, I should say identifying information, not just demographic information. If there's enough of that information available, then it's easier to classify it as a new case because you know it doesn't represent someone else who's in the system already. But sometimes there's not enough information to be able to sufficiently make a call about whether or not it's a new individual or not. So maybe they're missing a last name, or maybe they have a common name like John Smith with no date of birth. And in that situation, you can't tell if the lab report represents a new John Smith or if it's a lab report for one of the 14 different John Smiths with HIV who are already known to surveillance. If there's not enough demographic information, this group also goes into the possible case bucket. You hope to get more information as time goes on that might help you be able to make a definitive determination. So you need to revisit the people in the possible case buckets from time to time. Going back to the left side of the schematic, we realized we needed to further expand on the algorithm on persons previously reported to the surveillance system, in other words, existing cases for whom a new laboratory result is reported. This happens because people with HIV receive regular laboratory testing as part of routine care and treatment. If they change healthcare providers, there may be another round of diagnostic testing. So there may be a lot of reasons why someone who's an existing case in the surveillance system might have many laboratory reports each year, and sometimes that new laboratory information is significant. What do I mean by that? For example, maybe a person who was reported as HIV only before and all of their subsequent CD4 tests suggested that they have never progressed to AIDS. But then a new CD4 test result comes in that is less than 200, which means that they have advanced immunodeficiency. They've just met the AIDS case definition for HIV with AIDS, which needs to be reflected in the surveillance system. And this could have happened, for example, because the person was not on treatment or they stopped taking it for one reason or another. It highlights how you can use time-updated longitudinal information reported to surveillance to monitor things like disease progression. And that's because in New York, all HIV-related laboratory tests for an individual with HIV are reportable over time, even if that person has already been captured by surveillance in the past. This opens up possibilities for a host of important epidemiological analyses that can be queued off of the surveillance system. Finally, you can do routine matches of the HIV/AIDS registry with other registries that are related to HIV, as we saw in the hypothetical example earlier. For example, it's important for HIV/AIDS surveillance to know the vital status of people who have been reported to the HIV registry. Have they died since they were reported to the registry, or have they died since their last laboratory test was received by the system? This allows you to monitor the death rate and survival among people with HIV. And since survival from HIV depends on continuous access to treatment, deaths represent important missed opportunities for HIV treatment, and epidemiologic analyses of risk factors for death and poor survival will suggest important avenues for improving access and continuity of HIV care. And as mentioned before, it's important to review the death registry as well for people who have died from HIV that were missed by routine case finding altogether. And this can help understand where cases might be falling through the cracks of the surveillance system. And there are other registries that may be relevant or important to match with besides the death registry that can give you useful information, such as the tuberculosis registry, the cryptosporidiosis registry. These are both opportunistic illnesses that people with HIV are susceptible to, or the housing registry, which can allow the health department to assess the impact of the HIV epidemic in New York City's homeless population. Through routine matches, say every year, between the HIV registry and some of these other registries, it's possible to greatly augment the amount of information and the utility of the HIV surveillance system. So that helps give you a sense of the flow of data and information from all the different possible data sources that feed into the surveillance system on a daily basis. But of course, it doesn't stop there. The data received must also be cleaned, processed, classified, and analyzed, and ultimately translated into interpretable and actionable epidemiologic information. One of the first things we were interested in knowing from the new surveillance system was a basic description of the people who were newly diagnosed with HIV in 2001. How many were there? And we wanted to know whether there were important differences between those who were newly diagnosed in 2001 and those that were prevalent cases of HIV diagnosed prior to 2001. We were also interested in understanding which of the new HIV diagnoses occurred around the same time that a person develops AIDS. In other words, that group of people who had HIV long enough but went so long without testing or getting diagnosed that they developed AIDS, and that was the first time they learned of their infection. This is a really important group from an epidemiological standpoint, as it drives both onward transmission as well as the death rate. So we developed a whole bunch of algorithms that are shown on the slide here that we outlined the definitions and processes to translate all of the data elements into relevant epidemiological categories and related information. The big epidemiologic buckets that we list here are people with incident or new HIV diagnoses, people who were diagnosed concurrently with HIV and AIDS, and people who were diagnosed with HIV and or AIDS prior to 2001. We could bring in census data as well to calculate the rates of these outcomes. So what are some of the things that we learned from the first full year of HIV surveillance in New York City? Once we developed some epidemiological classifications, once we developed and applied them to the data elements in the new surveillance system, we were able to calculate things we didn't know before, like the HIV diagnosis rate, or the number of people diagnosed with HIV, and the prevalence of diagnosed HIV, including AIDS. So looking at the graph, we found that the overall HIV diagnosis rate on the top here in 2001 was about 0.75 per 100,000, or close to 1 per 100,000 New York City residents. And by using census data to calculate rates, we could see which groups are more or less likely to be diagnosed with HIV. We found major racial, ethnic, and gender disparities in the HIV diagnosis rate, and here as an example with Black males having 4 times the rate of HIV diagnoses compared with white males. And looking at the bottom graph, you can see the overall prevalence of diagnosed HIV, which we could now estimate for the first time using the surveillance system. I want to underscore that this represents the prevalence of diagnosed HIV. People with undiagnosed HIV infection can obviously not be represented in the surveillance system, meaning that these estimates are by definition underestimates of the true prevalence of HIV, which would include both diagnosed and undiagnosed. That said, we estimated that 1% of all New Yorkers were diagnosed and living with HIV, and we could further break this down by race, ethnicity, and sex to show a very high prevalence among Black males, 2.3%, 1.6% among Hispanic males, 1.2% among non-Hispanic Black females, and 0.2% among white females, for example. Here, a 6-fold higher prevalence compared with Black females. Black females had a 6-fold higher prevalence compared with white females. These were new and striking and surprising data to come out of this new surveillance system. These new data inspired our health commissioner at the time, again, Tom Frieden, to develop a slide that highlighted the major disparities with the intent of advocating for more attention and resources to focus on them. Having the health commissioner highlight surveillance data in talks and speeches and media appearances, and today social media, is an example of a surveillance system dissemination activity that can be very effective. The slide here shows that compared to the US, where 1 in 250 people were living with HIV, it was about 1 in 70 in New York City. And just looking at African Americans in New York City, about 1 in 40. And 1 in 10, or 10% of men who have sex with men were living with HIV. 1 in 8 injecting drug users. 1 in 5 black men aged 40 to 59 in Manhattan. And 1 in 4, or about 25% of men who have sex with men living in Chelsea. These prevalence estimates were staggering and very powerful tools to focus people's attention on New York City's HIV epidemic and on some of the disparities that existed and continue to exist. The surveillance system captures information on HIV transmission risk of cases, as we saw at the national level, and you can see pretty clearly that a limitation of the surveillance system in New York City is that of the 6,600 people or so who were diagnosed with HIV in 2001, 34% of men and 50% of women did not have information on the likely mode of HIV acquisition. And that's because this is a hard piece of information to get from providers, and laboratories, of course, wouldn't have this information. So a lot of effort goes into educating providers about the importance of ascertaining and documenting transmission risk factor information. Surveillance staff would routinely explain to providers and say things like, "We really need you to report risk information along with your cases." And the providers would often say, "Why do you need this information? We already know how HIV is transmitted. Why do you need us to report this information to you?" And then after exchanges like that, some good conversations could take place and allowed the health department staff to explain an important point that perhaps they weren't making, which is that why we need the data. We need it because understanding the distribution of risk among people with new HIV diagnoses allows the health department to target prevention resources where they're needed the most. And so, armed with a better understanding of how the data were being used by the health department, the completion rate of risk information began to improve over time, albeit slightly. But the take-home message here is that those with transmission risk information available, the predominant modes for males were men who have sex with men, followed by IDU and heterosexual transmission. And among women, it was mostly heterosexual and IDU, or injecting drug use. Again, large portions of unknowns, but this looks a little bit different than what the national data were showing us at the time. So the New York City Department of Health does a lot to disseminate HIV surveillance information. In fact, you've already seen some of the dissemination materials that come out of the surveillance system. One of them was part of your readings this week, which is the MMWR that formally described the implementation of named HIV reporting in New York City. But there's also an annual HIV surveillance report that the city puts out. This report from 2021 documented a 14% increase in new HIV diagnoses. That likely reflects a rebound in testing that had slowed down earlier during the height of the COVID-19 pandemic in 2020. This report also estimated that 78% of all people living with HIV in New York City were being successfully treated, with their most recent viral load test being undetectable. This is a nice visualization on the history of the HIV epidemic in New York City that accompanies the surveillance annual reports that the health department puts out. It shows all of the surveillance information going all the way back to 1981, starting with AIDS diagnoses. And you can see the additional information that gets added on as a result of the expansion of HIV non-AIDS in the year 2000. And along the x-axis, you can see the many relevant historical developments related to the HIV epidemic, such as the case definition and the case definition changes that happened, and the availability of highly effective antiretroviral therapy as treatment for HIV. So you can see from this graph, for example, the dramatic decline in the HIV-related deaths in green, and you can also see that it started to level out around 1998. It didn't decline as rapidly as we would have liked, given that HIV/AIDS treatments were highly effective and, for the most part, universally and freely available through the Ryan White Care Act. The fact that there were still thousands of deaths per year due to HIV in the treatment era reflected something important around access to care that surveillance data highlighted. And this is the kind of information for action that health departments can use to really improve outcomes in the medical care system and in the public health system. Here's an example of how that phenomenon was drilled down a little bit further to understand a bit more about access to care. The blue map on the left shows the prevalence of HIV, or the proportion of people in a given neighborhood living with HIV, diagnosed HIV in 2021, sorry. And the greenish map on the right shows the age-adjusted death rate among people with HIV who were alive at the beginning of the year, 2021. So one thing you might notice is that some of the areas most affected by the HIV epidemic on the left in terms of prevalence are also among those that are most affected by death rates. But there's also some areas that are highly affected by prevalence, such as the lower parts of Manhattan over here, but nonetheless have lower death rates on the right. And this highlights that differential access to care issue, that it depends on where you live, among other things. And it's more another example of the information for action needed by policymakers and for programmatic staff at the health department to help improve public health outcomes. Another very important surveillance data dissemination resource for New York City and the rest of New York State is the Ending the Epidemic Dashboard System, or ETE dashboard. It includes interactive data visualizations of HIV/AIDS surveillance data for all of New York State, and it also includes other related data and metrics. It's part of New York's efforts to end the HIV epidemic as a public health threat. It's a statewide initiative, and our team at the CUNY Institute for Implementation Science in Population Health was asked to develop this and maintain the dashboard system that tracks all of the metrics and targets related to measuring progress towards this ETE initiative's goals. And as you can imagine, surveillance data play a very central role to that end. So I'm just going to link out here quickly and give you a sense of what it looks like. So this is the ETE dashboard splash page, and the top banner here gives you a sense of what the dashboard is all about, what it's tracking, and if you scroll down a little bit, you can see some of the metrics. There are many, many different metrics that we track in this dashboard system, but I'll just want to highlight here in the middle is the HIV diagnosis metric tracking. You can see the trend over time and the actual number of diagnoses in New York State in blue. And in orange, we have the targets for the initiative, and you can see that the actual diagnoses are above where we want them to be in relation to the targets. Also coming from surveillance over here is viral load suppression among all people living and diagnosed with HIV. You can see the trend line in blue. Again, the 85% goal is not being achieved at the moment. It's 75% statewide, compared with the 85% goal. But here's this is an example of how we're tracking trends in some outcomes to monitor the progress of the initiative, largely using surveillance data. And I'll drill in a little bit more deeply here. You can go to the directory, you can see all of the different metrics, and I'll just scroll down here to look at trends among people with newly diagnosed HIV. And it has its own dedicated page here where you can choose to look at New York City specifically or look at the rest of the state. I'll just go to New York City here. And now you're able to look at the number of new diagnoses that are happening over time. You can also choose to look at the rate. For example, bringing in census data. And then you can stratify some of these trends by different sociodemographic characteristics, such as gender, such as age. And when you filter, when you're looking at the totals, you can filter also by UHF neighborhood. And you can see the extent to which HIV diagnosis rates vary by New York City neighborhood. Here's the outcome of concurrent HIV/AIDS diagnoses that I alluded to earlier, So what is the trend in that? You can see that there really hasn't been that much progress in reducing the proportion of people who are diagnosed with AIDS at the time they're diagnosed with HIV infection. And again, you can begin to see how this varies by neighborhood. It might help inform how you want to target HIV testing activities. And you can also break it down by different groups. If you go back to the borough level map, you can break down this indicator by different groups, and you can toggle them on and off if you want to simplify the graph that you're looking at, for example. The other metric I want to highlight is what's going on with the care continuum for people with newly diagnosed HIV. This is a popular one. I'm going to go to New York City again here. And what this is saying, that of the 1,592 diagnoses that happened in 2021 in New York City, 80% of them linked to care within 30 days of their diagnosis, 88% of them linked within 3 months, and 55% of them had achieved the treatment outcome of viral suppression by 3 months. So this is a way of tracking the extent to which the care system is working for people who are newly diagnosed with HIV. It's an important programmatic indicator. If you're interested in HIV surveillance in New York City, you can check out please check out the ETE dashboard. And there's also a national version of this called the AHEAD dashboard. So before we wrap up, let's consider some of the strengths and limitations of New York City's HIV/AIDS surveillance system, along with some of the relevant surveillance system attributes that we covered earlier and that are underlined here on the slide. So New York City's HIV surveillance system's strengths include that it's population-based and it covers all people with diagnosed HIV/AIDS, which makes it representative, highly representative. The surveillance system's completeness is very high also because of the active surveillance piece, as well as laboratory reporting, which can essentially be automated. Completeness of case reporting is likely above 95%, which is very unusual and very high for notifiable disease reporting systems. The surveillance system captures a large part of the HIV epidemic in New York City and the spectrum of HIV infection, especially now that the case definition has been expanded from AIDS to include HIV non-AIDS. The surveillance system links to New York City vital records and also to the National Death Index, and this latter linkage helps to ascertain deaths that occur among people who move out of New York City to another state. The system also has good timeliness with comprehensive dissemination, and it has a strong link to programs and public health action. The surveillance system's limitations, though, are that a substantial proportion of new diagnoses are missing information on transmission risk, which may speak to the acceptability of this part of the surveillance system among providers and with patients. Lastly, the system is complicated and a very large operation. Both of these are appropriate given what's needed here, but it does speak to the surveillance system attributes of simplicity and flexibility. The system is neither simple nor flexible in many ways. Finally, New York City's HIV surveillance system has strong links to public health programs and action. For example, Partner Services receives information on sex and needle sharing partners of people newly diagnosed with HIV from provider reports, directly from surveillance activities. HIV surveillance data are also used routinely by the New York City Prevention Planning Group, which uses the transmission risk data and other data to prioritize the distribution of HIV prevention resources. And then there's the Ryan White Care Act, which is a federal program that allocates funding to states and metropolitan areas to provide HIV care and treatment for those who are uninsured or otherwise unable to afford it. These allocations are based on the number of cases reported from each jurisdiction, such that surveillance data have a direct relationship to the amount of dollars, federal Ryan White dollars, for HIV treatment that are received around the U.S. by states. That about wraps it up for this week's session. Next week, we'll be talking about vital registration and vital statistics. Have a great week.